area of dentistry. For future information, please log into dentistchannel.online. Today, the topic is CBCT in dental implant. You can leave your question in the question answer box. At the end of the session, we will be discussing all your questions. And today we have our speaker, Dr. Sundaram Rajaram, MTS, FAS. Dr. Sundaram is a well-versed doctor with a proficient communication skills and impeccable clinical acumen. He did his UG from Rajaram Dental College and Hospital, and after that he completed his MTS in maxillofacial surgery from Meenakshi Ammal Dental College and Hospital from Chennai. With his keen and consistent learning, he completed fellowship in aesthetic facial surgery. He has a number of researches and papers are published, and he conducted extensive clinical teaching experience all around the globe. Dr. Sundaram, our esteemed speaker of the day, may I request you to take over the lecture now, please.
Dr. Thank Sundaram, you, Dr. Martina. Thank you, Dr. Martina, for the introduction. And a very good afternoon to everybody who have joined this event. And I'm glad to be in the virtual podium of the second World Implant Expo. And thanks for the wonderful opportunity, the Dentist Channel colleagues. And my topic of presentation is going to be CBCT in implant dentistry. Well, let me share the screen now. Yeah, I think my screen is visible now. Can I proceed?
Yes, doctor, your screen is visible. You can proceed, please.
All right, thank you for the information. And now, this presentation is mainly aimed at the beginners in implantology and dentists who aspire to become implantologists in the future. And also, it will be a brush up for more of the experienced implantologists who might have joined the event. So what can you learn out of this presentation? You might get a general idea about the radiographs and CBCTs, because radiographs would be the main workstation investigative modality for all the dentists in the chair side. And you would also get an idea of how to identify the radiographic features and radiographic shortcomings. So when we talk about implant dentistry, it is all about precision. So how good is a radiographic feature is being analyzed is all that matters. And where is the defect, you need to find out. And when next you need to go for the upgraded mode of investigative modality is all that you need to know. You'll be getting to know about it in this presentation. And what is CBCT? What are the advantages and shortcomings? So everything comes as a package. If you get some advantage out of a CBCT, you have a flip side to it also. So we'll be discussing about that too. And whenever we indicate a CBCT for a particular patient, you need to prepare the patient for the CBCT. So how do you prepare the patient for the CBCT is all you got to know will be demonstrated in this presentation. And also I have a video presentation and pictures of how to analyze using a CBCT, the implant planning. Okay. Now, this slide presents the grand plan of how an implant treatment is being carried out, right from the diagnosis of having a missing tooth or a failing tooth, which you see clinically, and the sequence that happens all through till you place the implant and give the superstructure or the final prosthesis on top of the implant that has been placed. So all through you will be, if you would look at this flow chart, there is something known as diagnostic imaging. So it is only in this diagnostic imaging which we are going to focus upon. So what other investigative modalities are available for implant planning? It is going to be the regular radiographs, and of course the most recent one is the CBCT. So in radiographs, what do we have? The most routinely practiced, that is the intraoral periapical radiograph and orthopantomograph. So as you can see in this picture, this is a diagrammatic presentation of how an intraoral periapical radiograph has got its own principles. So in this, you could see a conventional intraoral periapical radiograph will be having a white film that is placed intraorally opposing the tooth, with the tooth of interest or the subject of interest in between, and you get an outside X-ray source which passes on the X-ray beam. So you have the paralleling technique, you have got the bisecting angle technique through which you get the regular radiographs, that is intraoral periapical. And now this is the advancement of the conventional radiograph, wherein the film is replaced by an electronic sensor. As you all would be knowing, because these are most commonly available these days in each dental clinic. So the film is replaced by this electronic sensor, and this sensor, once the X-ray is done, this is connected to the computer display monitor. So once the X-ray source emits the X-ray, you get the image formatted in the display. So which is really very convenient because it reduces the work time of the dentist whomever wanted to diagnose what is inside the jaws of the patient. Now, this is a pictorial representation of the orthopantomograph, that is the OPG in simple we used to call, wherein the subject of interest, in our case is the patient, stands at the center, as you can see in this picture. The X-ray source moves in this case. You know, the X-ray tube head would start at one end and then it goes on till the other end. And subsequently, the film that records the images also starts from one end and then it finishes at the other end, giving a panoramic view of the jaws of the patient. So these would be the routinely done radiographs. Now, if a chairside radiograph is available and it is sufficient enough to know how much of bone is available and where is the place of edentulous region and what exactly is placed inside the bone, where to place the implant, is there any pathology available, or should we look upon anatomical barriers? So if we have an idea of all these with the regular chairside X-ray, then why do we need to go for a superior version of investigative modality like a CBCT? To answer this question, let me take you through a couple of radiographs in the ensuing slides, where you will get an idea of how relevant the radiographs are available for implant planning. Now, this is a simple radiograph of the upper anteriors. And what do we see over here? We see the upper anteriors are shortened. They are not of actual size. You can see one of them is elongated, one of them is shortened. So you don't see proper angulation in such a radiograph, which is also a common scenario as far as an intraoral periapical radiograph is concerned. Now, again, because of the improper angulation, you can see elongated images of the tooth. For instance, if I'm going to remove this root and place an implant over there, I'm really not sure of what dimension of implants that I can place over there. This is another radiograph where you can see the premolars, the molars of the upper, and you can see the thin radioradial line that is crossing the roots of the upper posteriors, which undoubtedly is the maxillary sinus. So now even this will not be able to give us a precise value of measurement of what dimension of implant that I'll be placing over there. And you get the same problem in the maxillary molars also. You get the sinus, but you're not sure how far the sinus is dropping to. You are not sure. This image gives us a prediction that the maxillary molars are dipping into the sinus, but are they really going to the sinus or it's a different plane? We have got no idea. Now, this is the radiograph, intraoral periapical radiograph, the lower molars, where you can see a hazy radiolucent region below this area. You can little bit see the mandibular canal in this region, but you're not sure whether it is continuing or not, and you see a hazy generalized radiolucent area. This is the submandibular fossa that is seen in the intraoral periapical radiographs. Now, what is this structure? This is the incisive papilla region of the upper incisors. They're present between the upper incisors. Now, for instance, if I'm going to plan up for instance, one of the incisors is missing, and I need to plan up an implant in this region, I'm equally concerned about the contents of the incisive canal in this region. So my space for the implant is only going to be limited up till here, and not up till here. And if my implant is going to come up till only over here, then what about the crown that I will be placing on top of it? So that will be having a bit of mesial cantilever that would come up till here. And how far deep is this implant going to be? Maybe up till here. Even then, the dimensions of which also I'm not completely aware of. What other structures you could see in this radiograph are, you can see the superior foramina that is present over here, and it continues as the incisive canal down. There, this is another radiograph of the upper lateral and canine, which shows a bizarre radiolucent area in between. So what could this pathology be? This is nothing but the lateral fossa, and which is not a pathology. So you get to see artifacts related to normal anatomy or anatomical variants. So this could commonly be mistaken for pathology like globulomaxillary cyst. So such uncertainties are always associated with two-dimensional radiographs. This is yet another picture where the angulation is not proper, but you could see other precise anatomical features, like 1 points to the nasal fossa, the 2 points to the inferior nasal turbinates, the 3 would be the bony nasal septum, and the most radio-opaque region, the spine, the anterior nasal spine, is also seen. Now, what about the teeth? The teeth comes up till the floor of the nasal cavity, and even then, it's because of the improper angulation. I'll not be able to say precisely if in case I'm going to place an implant over here, I will not be able to precisely tell where and how and what dimension of implants that I would be putting over there. This is an interesting image of a radiograph where you could see 2 cavities, one over here and one over here. Number 2 undoubtedly is the maxillary molar, maxillary sinus, because it is consistently associated with the maxillary premolars and molars. So this would be the sinus cavity. And what would be 1? The 1 is nothing but the nasal cavity. So this would be the border of the nasal cavity, and this would be the nasal cavity, and which is superimposed onto the maxillary sinus. And this is another image of radiograph of the upper posteriors, wherein you can see a well-defined radio-opaque line demarcating the maxillary sinus. Sorry. And what is the next line that is present over here? This is the superimposition of the floor of the nasal cavity that is seen over here. So this is a problem, dear viewers, with two-dimensional radiographs. So you get a lot of superimposition, a lot of soft tissue shadows that can actually hamper the images or the information that you can actually get out of a radiograph. This is the radiograph of upper posteriors, edentulous region. And this thin line of shadow is nothing but the nasolabial fold that you can see running across it. So whenever a maxillary tooth that is in close approximation with the maxillary sinus has been extracted, there's a very common scenario for us to see after some time that the maxillary sinus dips down and then goes up. So this natural phenomena is known as pneumatization of the maxillary sinus. And the reason why it happens, we do not know. And for some unknown reason, the maxillary sinus can dip down, but will not completely erode the crestal cortical plate of the maxilla. Again, if I'm going to place the implant over here, I I don't have an idea of how far bone is available and how far bone grafting I'll have to do, how much of sinus lifting I'll have to do, what is the surface of the floor of the sinus over there. Is going to be flat or is it going to be undulant? If it is going to be undulant, I'll have to think only of doing a direct sinus lift. If it is going to be an even one, I can think of doing an indirect sinus lift. So all such questions come to our mind. So all such radiographs in a two-dimensional way, it puts in more questions rather than bringing us more clarity for the answers. So what could this structure be? This is the zygomatic process of the maxilla that you see as a very strong radio opaque structure. This again, it disrupts the view of the available bone in the region of interest. This is the periapical radiograph of the lower anteriors, wherein you can see a lot of lucent lines running from the epiphysis towards the body or the symphysis of the body. Now, what are these? These are nutrient canals. And why are these relevant? They're relevant because once you go deep enough and then you venture on the nutrient canals, it is obviously going to bleed. Of course, once you place the implant, it is going to be self-limiting, it's going to stop, but you are going to see more bleeding than usual. So now, this again warrants for a better investigative modality. Now, what is this structure? This is something known as a mental fossa that gives us a hazy appearance of radiolucency. So, and also it gives us a vague opinion of some form of periapical infection, which is actually not. This undoubtedly represents the periapical pathology of the first premolar in the lower, and this is again an improper angulation of the intraoral periapical radiograph showing the inferior canals that's been really elongated, which is not actually so, right? The number one represents the normal anatomy, that is the mental foramen. In this case, can easily be mistaken for a periapical pathology associated with number 4. And the number 2 is not a canal, but it is the submandibular fossa that gives you the generalized radiolucent appearance. So things can really be very tricky as far as the radiograph is concerned. Now, what could this radiographic feature be? This is the thick bone of the lower border of the mandible. The inside part of it will be showing the mylohyoid ridge. So that shows up as a very thick radiopaque line that you can see in this picture. Now, what could this be? This gives an appearance as though the mandible body is really thinned out, which is not actually so. This is an image because of improper angulation, and the line that you see over here is actually the internal oblique ridge, and the space that you see at the below this line is nothing but the submandibular fossa. Now let's move on to some of the pictures of orthopantomogram. So what you see over here, you could see some of the artifacts present over here because of the overlying spine that comes in the way. Now, if you look at this orthopantomogram, I'm not able to see any of the epiphysis of the upper teeth. So that is the problem with orthopantomogram. You will not be able to see any of those. And also, if you would see the radiolucent line that is present over here, it represents the palatal shelf. There is only one palatal shelf and it's supposed to be a single line, but it is not. You can see double lines over here. So which means the angulation of the head while the orthopantomogram is taken is not proper. The patient is a little bent down so that it appears as double line. Now this again, you can see it's an exaggerated smile of the patient. Again, is because of improper angulation of the head of the patient. The patient has tilted more down the head, and that results in an image like this. Now, this is an image wherein you can see a narrowed down anteriors of both the upper and lower, whereas broadened or magnified upper and lower posteriors. Even this image, although I'm very sorry for the clarity, but even this image depicts the same. You got very narrow upper and lower anteriors, but very broad apart posteriors. Again, this is because of the spinal superimposition. If I'm going to plan up for implants in this region, I will not be able to study completely of what bone available, what is the bone available that is in this region. Now, what is this hazy radiolucent structure present over there? That would be the tongue space. So whenever a patient is not sticking the tongue towards the palate, then such an image would happen. And now the problem can happen with the radiographs, and there are some acceptable and well-documented problems that can happen with the perceptor, that is the clinician or the operator, whomever is interpreting the radiographs. So once the optimally made image is viewed under optimal conditions by trained and experienced clinician, that image should be optimally interpreted. Unfortunately, physiological phenomena with each clinician may exert their influence. The Mach band effect is ubiquitous in radiology and occurs at the junction of two regions of different radio density. If you would see this X-ray, you can see one radiopaque image lying over here towards the lower border of the mandible. And this varies in density, and the body of the mandible varies in density, and it appears as though there is a difference in the densities between the two structures. And this actually at different angulation would reveal that it's only the hyoid bone that is interfering. So the Mach band actually arises within the retina and results from the physiological process of lateral inhibition. So with stimulation of a receptor, in addition to initiating the transmission of an impulse toward the visual cortex, inhibitory impulses are being transmitted to neighboring receptors, preventing them from also discharging an impulse back to the visual cortex. The idea is that you will not be able to precisely see the borders. So that would create, again, an artifact. Now, so far we had been looking into all the inconsistencies a radiograph can cause. So because the conventional intraoral and panoramic radiographs can provide only anatomical information in two-dimensional way, but we are talking about something known as implant dentistry, where it is all about precision. You want the implant to be placed in a 3D space, which is surrounded by bone in all the dimensions. And of course, we also have to respect the anatomical barriers like incisive canal, the mental foramen, the infradental canal, the maxillary sinus. So what do we do then? So it is only then we go for a higher authority, that is something known as a CT scan. Now, what is a CT scan? As you can see in this picture. So far the radiograph works on a principle of X-ray source that falls on an object, and that has been projected on a film, captured on a film, and that's what the two-dimensional figure is all about. Now, as far as a CT is concerned, the object of interest rotates, but in our case, the patient is the object, so we'll not be able to do that. So for that, we introduce something known as a CT, in which the X-ray source keeps revolving around the object of interest, that is the patient. And once the CT captures all the information in all the 360 degrees in all the planes, that is projected in so many slices as a 2D image. And we have got specialized software which would convert those pixels. Whenever it is in 2D, it is known as pixels. Those pixels are clubbed together, they merge together, and then they are reconstructed into a 3D image. Each functional unit of a 3D image is something known as a voxel. So the pixel is converted into a voxel, and then that is being projected as a 3D image on the display of the computer. So this is how a CT actually works. Now the CT also has got its own evolution. The first one is going to be the linear tomography. A linear tomography, as you can see in this picture, has got the object of interest in this place, that is a patient. You got the linear film motion and the tube that rotates around the patient, right? This is how the linear tomography was being done. But it demonstrates the anatomy of a section of the jaws in flat buccolingual plane. The typical slice length is about 3 to 6 millimeters, and each examination series would probably consist of 3 to 4 tomographic cuts covering a 1 to 2 teeth region. So there is always a typical magnification of 1.4. So it displays a magnification. So obviously it is not our cup of tea or what we expect. So there was the next development in the field of CT, something known as helical CT. The source of the X-ray kept revolving around the patient in a spiral motion, giving us the valid information as we need it. So that is all about helical CT. This picture demonstrates the main difference between a linear and a helical CT. So in this first picture, there is a single rotation of the X-ray source, and then the patient on the structure will be moved a little, and then comes the next circle of round. This is what the linear CT is all about. The helical CT does a continuous spiral of motion around the patient, making possible all the 360-degree slides that are needed. So this would be the principle of a hospital-based CT. Now, what is CBCT? CBCT, as you can see in this picture, has got the patient at the center. The X-ray source is over here, and on the opposing end, you've got the sensor plate, and they keep rotating in all the 360-degree directions. And you could see all the voxels that are being reformatted, and they are displayed onto the computer monitor as axial, sagittal, and coronal images. Now, how different is this from a regular hospital CT? Why don't we go ahead with only a regular hospital CT? Is the next question. Now, this image is the main difference between a regular hospital CT and a cone beam CT. So in this picture, it is a fan beam. So any of the spiral CT, helical CT, hospital CT, it mainly involves a fan beam. The X-ray would be as a fan beam. It is something like the light coming out from a torch. It is always divergent. Whereas the cone beam CT has got the X-rays concentrated in the form of a cone, and the FOV, that is the focus of window, is going to be highly concentrated only on the areas or the anatomy that are really very relevant. So this makes the huge difference and the obvious advantages of why we choose for a cone beam CT rather than a fan beam CT. Okay, so what difference does it make image-wise? The pictures that you see on the right over here are helical CT images. The pictures that you see onto the left are CBCT images. So if you can see here, this is actually failing implant. Failing implant that is put onto the nerve. But if you wanted to go to the cross section of it, of course you can see the implant radio opaque, but you are not able to precisely see where the nerve is. Whereas come to this picture where the CBCT images are present, you can see the implant. This again is a failing implant where it is failing because of the lingual cortical plate perforation. So the details are precise and better, and spatial orientation is also better as far as CBCT is concerned. Now let me take you through a couple of images that are ensuing the presentation of how important the CBCT is relevant as far as implant placement is concerned. So this would be the coronal, the sagittal section of the alveolar region, showing the upper and lower alveolus with the upper and lower anterior teeth. And you can see a faint radiolucent line running till the center of the body of the mandible. So this would be the lingual canals. And how significant is the lingual canal? the moment we breach, for instance, if I'm planning for an implant here, the implant comes up till here. If I breach the lingual canal, this is going to this might end up in bleeding. And this bleeding is going to go into the sublingual space, and that you don't have a stop in that region. It's a very rare happening, but if it strikes you really very hard. So that is something to be borne in mind when you look for a CBCT, and especially when you're planning for an implant in the lower anterior region. Of course, anatomy always comes with variance. You have got variations in anatomy in this place where you got multiple lingual canals that you can see. You can also see variations in the incisive canal. Probably in the first picture, you see the incisive canal runs over here. You got the incisive canal, the second image running continuously. And sorry, you have in the third image, you've got the incisive canal abruptly ending at this place. So you don't have anything at this place. And probably in the first image, the incisive canal probably assist. It is developing to assist probably. And this picture denotes the presence of a STAFNE defect in the mandible. As you can see, the borders are well defined, and the history would reveal for a long time, which is asymptomatic. This slide depicts the maxillary sinus. For instance, I am planning to remove the upper molar over here and then planning for an implant, and I need to study the sinus. With an intraoral periapical radiograph, probably I will get an idea of where the sinus lining would be. And I would definitely be planning for a sinus lift, bone grafted, and then wait, or I can immediately place the implant depending on the situation, without having any idea of what is happening inside the sinus. As you can see, the sinus lining is really hyperplastic, it's really thickened, and you need to and also the next question is, you need to know why is it happening. In this case, probably it is happening because of the chronic infection from the infected tooth roots that are present over here. And again, the nature comes with so many variations. You can see multiple mental foramen in this case, which is quite unusual. Whereas on the other side, it's only one. And whenever we operate in cases of the lower premolar region, we generally look for the mental foramen by a special maneuver. So you make an incision, raise a flap, and then you gently probe, gently get a blunt probe down up till here, and then check for where the mental foramen is, and then you can go ahead placing your osteotomy. Now, this procedure or this maneuver is safe as far as you do this probing in a gentle manner. And as you can see, this is a special image where you've got a lot of vascular ramifications. This is the infradental canal, and you get lots of vascular ramifications. And without knowing, if you are going to place an osteotomy here, of course, you're going to land up with bleeding. So these are certain places where the anatomy is little perplexing and unusual, which a regular radiograph would fail to highlight them, whereas a CBCT could catch them. And this would be an unusual case of bifid infradental canals. You got two bundles of vascular channels running and intertwining. So these again would be missed in a regular radiograph. The significance of a CBCT is of great importance when it comes to post-implant surgical phase, when you want to evaluate peri-implant region, when you want to know what would be the prognosis of the implant that has been placed. Now, if this implant that you see in this picture has been seen on a regular radiograph of orthopantomogram or intraoral periapical radiograph, it is going to give a very good picture. I mean, the prognosis is going to be really good. That is the image that it is going to give, because it's purely two-dimensional. But whereas it is only these cross-sectional slices that would actually tell us that there is insufficient bone on the buccal, there is no bone on the buccal side. So in fact, this is a failing implant. This is yet another picture which we have seen it previously. This is the orthopantomogram view. Of course, it's of the CT, but even the OPG gives you the same effect. It is nicely surrounded by bone, so it's a healthy implant is what we all think, but it's only the cross-sectional slices that would give us an idea that how far the lingual plate has been perforated, and this in fact is a failing implant. Now, there are certain cases where we find the CBCT is superior, but is it really appropriate to take a CBCT scan for all the implant cases is the next question that raises. Now, let me take you to the further slides. See, undoubtedly, the spatial resolution of the CBCT is way too better than the radiographs and also the hospital CT. And it obviously has got a very good 3D reconstruction modality. And whenever we talk about 3D reconstruction doesn't aid in any planning, be it implant surgery or be it traumatic surgery. 3D reconstruction is mainly for patient education. You're going to show this 3D reconstruction to your patient, and then you need to tell that this is where the implant is going to come. Now, this resolution is always better in a CBCT rather than the hospital CT or any of the 2D formats. The next concern we all have about CBCT is going to be accuracy. Is it that accurate? Is all we talk about. We have got n number of documentation which says that the reliability of the accuracy of CBCT is really high, and it can account for a little magnification and or a little degraded value on a negligible basis. In short, it is acceptable. And these are the reasons why precisely we leave a margin of about 2 millimeters whenever there are anatomical barriers like the inferior dental canal or the maxillary sinus are coming the way. Now, whenever we decide on any investigative modality, we have to weigh the risk versus the benefit. Which one outweighs the more? And that is what will make us indicate whether to use that investigative modality or not. The cone beam CT also comes with the flip side defects. Like, see, in this case, this is an axial image of a patient who's got a CBCT done. These are scattering images that you can see as because of the heavy metals that are being used. As far the more noble the metal that is being used, the very less scattering or almost nil scattering happens in CBCT. So for instance, the titanium that has been used in implants, it doesn't scatter really much, or it's almost nil scattering. Now this is a sagittal view of the upper and lower joint, the anteriors. You can see the alveolus, you can see the dentition, but you're not able to see the attached gingiva, you're not able to see the lips, the orbicularis, so all these features are very poorly defined. As far as, but as far as the implant dentistry is concerned, we think about only the viability of the bone. So such poor soft tissue definition can always be ignored because in short, we do not use them. So next major concern that we all have as responsible clinicians are, what would be the radiation exposure that the patient will be receiving? So this slide depicts us, so all this radiation exposure are being measured in millisieverts. So the panoramic radiograph, it ranges from 4.7 to 14.5. The highest film is going to be 26. And you can see the cone beam is only 25 to 60. Why does it come in a range? It comes in a range is because different manufacturers will be having different recommendations. So that is why you have a wide range over here. In fact, if you want to make a full mount series, it goes up to 150 millisieverts, which is more than that of the cone beam CT. And of course, the medical CT, 1200 to 3300 millisieverts, which is really, really high. So these are the reasons. And I think these recommendations also respect ALARA, that is ALARA recommendations too. So now we again come back to the question, is it appropriate to take a CBCT scan for implant placement? Well, I would say in my experience too, it is, yes, it is appropriate to take a CBCT scan as far as implant planning is concerned. Now I'll take you through a series of slides wherein you will know how to prepare a patient for a CBCT. Now this slide represents the clinical pictures of an edentulous patient of the maxilla, class 4, Kennedy's classification. So whenever you plan for the implant in any patient, it is always better to know how the final prosthetic workup would be. So the patient is going to see only the crown and not the implants. Even the society sees only the crown, not the implants. So how beautiful, how wonderfully you place the implants is also important, but which is more important, which is more periodically significant is the superstructure that you're going to add. So that is why you always begin with the end in mind. Like my mentor, Dr. Shankara, has rightly said, begin with the end in mind. And this is what is technically named as prosthetically driven implant dentistry. So what do we do for that? When any case of such edentulous comes, what I would do is I would quickly prepare for a wax bite and then get a provisional dentures done. Now, once this provisional denture is done, I inserted it in the patient's mouth to see this is how the future process is going to be. Now, how was this helpful? Because after this, I'm going to construct a wafer. This vacuum wafer is helpful for me to create all such grooves. Once that is done, I create vertical grooves where the future implant is going to be placed. And these grooves are going to host any of the radiolucent, radio opaque material. For instance, the simplest one is going to be the GP points or the gutta percha points that you can see that are placed in the groove, vertical grooves that are placed on the wafers. And once this is done, I send the patient for the CBCT. The patient is supposed to wear these on and then sit for the CBCT. And what would be the image that you get in the CBCT is something like this. As you can see in this picture, the GP points are going to get highlighted as radio opaque lines, telling us where the future crown is going to come up with. And what is the adjacent available bone present and in what angulation and where exactly the implants are going to come. So this is the idea that our CBCT with specialized preparation is going to give us. Now, if this crown, for instance, this crown is not present, probably I would get the implant placed in this direction because this is the area of convenience to me and where more of bone is available. So which is going to create a very anesthetic appearance. You place an implant all right, but the superstructure of the crown is not going to come proper, the treatment is failure. And also you can see in this picture, a crown is going to come like this on top of it. Whereas if I'm going to get the implant placed directly like this, no, it is not going to happen well. That's how it is supposed to happen. If this is going to come up like this because the alveolus is bent up like this, it is not going to come in line with the crown that I'm going to place in the future. So these are the precise use of special preparations for CBCT that we do. In certain cases, you can also completely fabricate the prosthesis by mixing radio-opaque barium salt into it. So when you do that, make the patient wear the denture and sit for the CBCT, you are going to give you're going to get a completely radio-opaque superstructure, and below which you can nicely plan up for the implants. You can see the bone available over there. You can nicely plan up for the implants. Now this is a video representation. It's a pre-recorded video presentation of how to handle a CBCT when you receive one. So let me take you through this video. first step is to mark the curves. And then you're going to define the place where you're going to focus upon. You're going to reduce the window of focus so that you don't get distracted of other structures. And then you can go to this wrench. This wrench is going to tell us what view we are going to get. And that is for the magnification. And the next one you do is try to delineate the nerve. You're going to trace the nerve now. So once the nerve has been traced, I open up the implant library and then select the choice of implants that has been listed, and the dimension of the implants has been selected, and then I add that plan to the images, and then I get something like this. I'll be able to change the angulation. I'll be able to reposition the implant that is needed. I can even change the implant if I wanted to do so. So if I need to change the implant, what I do, I go back to the library and then go in for a longer one or a broader one. So without any change in the angulation, this is going to get applied. So now we are going in for something known as implant centric view. So as you can see in all these windows, when you change in one particular window, the change happens in all the views. So as you can see in this picture, this is a 3D rendering. You can show the patients that this is how the implant is going to come. You can see an extension that goes towards the top of the towards the top tooth, so that you know where exactly the opposing tooth is going to come and hit the lower one. And this would be the implant verification tool, wherein it is from top till bottom. You will be able to scan whether the implant that you have virtually constructed has got surrounding bone till all the length of the implant. Now, there's a very popular Tamil adage, that is, Kannal kanpadum poi, kadal ketpadum poi, theere visarapademi. The literal English translation is going to be, eyes and ears are always deceptive. In-depth analysis always reveals the truth. The recent introduction of CBCT has completely revolutionized the oral maxillofacial radiology and the implantology. In spite of substantial body of literature that has emerged, only very little of it is so far approximated the highest standards of clinical evidence. Therefore, its use, as with any other radiological investigation, needs to be clearly indicated for that particular patient. Nevertheless, there is a duty of care that all clinicians bear to ensure that each potential implant patient has properly been evaluated so that each implant can be safely placed with the patient with the greatest chance of success. Due to an overall reduction in radiation dose, increased availability, facility of simulation, and an understanding of the risks of implant placement, it is becoming only more difficult to justify not using a 3D imaging as a part of peri-implant planning. So thank you for the wonderful opportunity, my colleagues of Dentistchannel. And that's how I end my presentation.
Thank you so much, Doctor. Thank you so much for the wonderful session. Before going to the question and answer section, I will show a brief introduction about our company. Doctor, can you please switch off your screen so that I can share? Dentistchannel Online is a private living company of dental media company that aims to spread awareness and knowledge regarding various aspects of dentistry. We conduct regular webinar and courses on different areas of dentistry. Being a prime member of Dentistchannel Online brings you several opportunity and dental courses. Thank you so much. Now you can leave your question in the question answer box. As of now, there is no question. Participants, please, you can leave your question in the question answer box. Thank you so much, Doctor. Thank you so much for the wonderful session.
I should thank you a lot for the wonderful opportunity you all have given. Thank you.
It's our pleasure, Doctor.
Thank you so much.
Participants, you can leave your question in the question answer box. Sir, we have one question.
Yeah.
Doctor?
Yes, please tell me.
We have one question. The question is how we determine without soft tissue assessment about rejection.
About the projection.
I will repeat the question.
Yeah.
How do we determine without soft tissue assessment about the rejection? That is the question.
Well, as one of my slides, in one of my slides I've mentioned, the problem with CBCT is mainly the soft tissue resolution. And we are going to depend upon the CBCT only for the hard tissue and not the soft tissue. So when it is soft tissue projection, all that I could understand is the adjacent soft tissue that needs to be concerned. I feel our limit of dependability on the CBCT scans is going to be only, we just get an idea of what it is and how much of bone is available and where we can place the implants. Whereas whenever a soft tissue adjacent is going to come up with, I think the best known indicator is that clinically we open up and see. So that would be the best assessment as far as implant placement is concerned.
Okay, Doctor, thank you so much. We have one more question. The question is, are soft tissue analysis is required along with the hard tissue analysis?
Soft tissue analysis, as far as where soft tissue analysis becomes more important, it becomes in cases of where you have got a very thin gingiva, we've got the biotype, the thick and thin. So it is in such situations we are very much concerned about it. But unfortunately, CBCT doesn't give any valid and dependable information about any of the soft tissues. So when it comes to soft tissues, the best is going to be the clinical investigation. For instance, if you need to think about assessing the thickness of the gingiva, on top of the bone, the best is going to be you anesthetize the patient and you get a probe and then you pierce through it. So something like bone mapping got to do. So that would give us the actual idea of what amount of soft tissue is present on top of it.
Okay, doctor. Okay, thank you so much. I have one more question. The question is, are the soft tissue analysis, how effective is the role of CBCT in the cortical implantology? I will repeat the question once again.
Yeah.
How effective is the role of CBCT in the cortical implantology?
Okay, so I guess the question is aimed at depicting the density of the bone is also, I guess. So when we talk about cortical implantology, so when we talk about bone densities in a CBCT is going to give us a hazy figure of what type of bone it is. When we talk about cortical bone, it is D1 bone, right? So the image that we are going to get is going to be highly radio-opaque or less radio-opaque. But the actual value of how much of bone density is available, the CBCT is not going to give us a measure of it. The reason is all the measures that we do in a CBCT comes in terms of sieverts and millisieverts. If you want to really assess the bone density, then it should be in Hounsfield units. Hounsfield units will be a measure that you can ascertain in a hospital-based CT or a helical CT. Those would give you the actual measure of the amount of bone density that is available in the jaws. Even if you even if you check with some of the CBCT reports, they used to give us D1, D2, D3, D4, you know, those values, but they're not accurate. They may not be accurate.
Okay. Thank you so much, Doctor. There is one more question. The question is there any contraindication for CBCT?
Contraindication, I would say in situations where there is extraction and immediate placement. So in such situations, you don't need a CBCT, in fact, because you're going to extract the tooth, and once it is free of pathology, and also periodontally uncompromising areas, right? When there is a nice bone surrounding the tooth, you check the length of the extracted tooth, and then you put your osteotomy 2 millimeter more than the stipulated length of the root that has been measured. And then you can go ahead with simple radiographs, and that should avoid the use of CBCT. So in such situations, the CBCT is not recommended. Okay, doctor. Thank you so much. There is one more question. The question is, after implant placement, a post-cactus evaluation is required, or is radiograph evaluation and follow-up is enough? Yes. So once the implant is placed, the recommended post-operative investigative modality, if it is CBCT, it is better, because as in one of my slides I've clearly depicted, where an implant that has been placed functionally is also great, but is actually failing is because it lacks the facial bone. So such a buccolingual presentation would be ascertained clearly only in a CBCT. So, well, if you're really confident in your implant placement, you're really sure of, yes, I haven't breached one of the lingual, cortical plates, yes, you can avoid taking the CBCT. Otherwise, if you really think of having some defect is being done, then it's better you go in for a CBCT. Okay, doctor. Thank you so much. This is the questions I have received. So thank you so much, doctor, for the wonderful session. Thank you so much, participant, for your cooperation. There is one more session is coming up, 3:30. Please keep tuned.